everyone, and welcome to today's webinar, Measurement of Hemoglobin A1c and Diabetes, What You Need to Know. I'm Dr. Liza Kunz, Systems Director for Endocrinology and Reproductive Health at Abbott. Today's educational webinar will be presented by LabRoots and is brought to you by Abbott. To learn more, visit www.corelaboratory.abbott.com. We encourage you to participate today by submitting questions that you may have during the presentation. To do so, simply type them into the Ask a Question box and click Send. We'll answer as many questions as we have time for at the end of the presentation. You may also submit any technical issues here as well if you have any trouble seeing or hearing the presentation. It's my great pleasure today to be joined by Dr. Garry John, clinical biochemist and head of clinical biochemistry and immunology at Norfolk and Norwich University. This program is sponsored by Abbott, and I'm presenting on behalf of Abbott. The information contained in this scientific presentation is for me and does not represent any new or implied product or regulatory claims. I thought I'd start us off with a theoretical case from my clinical years. GD is a 44-year-old patient who has insulin-dependent gestational diabetes with her first pregnancy 3 years ago. Her hemoglobin A1c 8 weeks postpartum was 6.2%. Now she's planning a second pregnancy and presents for preconception counseling. In addition to her routine labs, her primary OBGYN sends a repeat hemoglobin A1c, which is now 6.8. The patient is asymptomatic, but wonders what this means for her health now and after a potential pregnancy. Does she have diabetes? I thought that would frame our conversation nicely as we move on to Dr. John's presentation. Dr. John, I hand it over to you.
Thank you for that kind introduction. Today we're going to be talking about the measurement of hemoglobin A1c, and debatably, in terms of patient outcome and patient care, is probably one of the most important measurements that we do within the clinical laboratory. We also cover what we need to know so that we can make the best use of the results that we produce within a lab for patient care. So I am grateful to Abbott for supporting today's talk, but the information I will give is purely based on my own clinical experience of providing a laboratory service, and also my experience of hemoglobin A1c measurement. So first, let's think of the history of diabetes. This is actually not a condition of modern living. Indeed, we can go back to ancient Egypt in 3,500 years BC, before the Common Era, where the ancient Egyptians were recognizing various aspects of what we now know of as diabetes mellitus. And they could see that when they looked at the urine which had passed with individuals with diabetes and comparing it to the urine in the sand of a patient who didn't have diabetes, that the ants were drawn towards, even the slow ant, towards the urine of the patient who was displaying symptoms of diabetes. So they could tell the individual was unfortunately going to die, and there was nothing they could do about it. Slightly more recently, in 1552, this papyrus, which was discovered by Egyptologist George Ebers in Thebes in 1862, described the symptoms of diabetes in terms of polyuria. So records go back to a long, long time ago, before, so into ancient history, that diabetes was around in those days. Slightly more recently, in the 1600s, Willis, a British physician and biochemist, described the urine of diabetics as having a sweet taste and associated that with good fellowship and drinking down of wine. 100 years later, Dobson, being slightly more scientific, isolated a dry residue from urine of diabetics, which looked and tasted like brown sugar. What was it with biochemists back in those days, tasting urine? I don't know. In the 1900s, Stanley Benedict devised a method for measuring sugar in urine. And of course, we now know this as Benedict's solution. And 10 years later, Folin and Wu published the first dependable means of measuring glucose in blood. And measuring glucose in blood remained the cornerstone of which we assessed glycemia up until the 1970s. And I'll come back to that. But in clinical medicine, Charles Best and Frederick Banting were the first individuals in Canada to isolate insulin from pancreas and were able to keep a diabetic dog alive using this preparation. We all remember Charles Best and Frederick Banting, but let's not forget the dog. Her name was Marjorie. And if it wasn't for Marjorie, Best and Banting, we wouldn't be where we are now in the treatment of diabetes. This year shows young Leonard Thompson, 14 years old at the time of this picture. He was the first patient to receive insulin on the 11th of January, 1922. At this point in time, his blood glucose was extremely high. He was going in and out of consciousness, and he was passing about 5 liters of urine a day. The only way we could treat diabetes back in these days was by a low-calorie intake diet. Even so, type 1 diabetics had little or no chance of surviving weeks or months following diagnosis. Following treatment with insulin, young Leonard Thompson survived and did well. He survived until he was 20-odd, mid-20s, where he unfortunately died of pneumonia. Before the use of insulin, everybody with type 1 diabetes would die. The new challenge now, following the discovery of insulin, was how to control glycemia and how to prevent complications. So we got 3 questions. Why do people with diabetes need to have good glycemic control? How can we monitor glycemic control? And does improved glucose control improve the outcome for people with diabetes? Let's address the first question. Do people with diabetes need to have good glycemic control? Well, we know that if they have poor glycemic control, there is a number of complications associated with diabetes. And these complications affect almost every organ in the body, as well as blood vessels, skin, etc. Let's look at 1 or 2 of these in more detail. Diabetic retinopathy. 7% of people who are newly registered blind in England and Wales have a sight loss due to diabetes. And in 20 years of diagnosis, 2/3 of people with type 2 diabetes will have some degree of retinopathy. Lower leg amputation, a major issue in diabetes. Minor trauma, for example, from ill-fitting shoes or slight injury, can precipitate foot ulceration, leading to lower limb ischemia and lower limb amputation, a major issue. Diabetes is one of the major causes of lower limb amputation worldwide. Diabetic neuropathy. Peripheral neuropathy is estimated to affect up to 50% of people with diabetes. And as time progresses, this neuropathy persists with persistent neuropathic pain, a major debilitating factor in diabetes. Diabetic nephropathy, probably the most important of the complications related to diabetes. We know that end-stage renal disease is up to 10 times higher in people with diabetes compared to people without diabetes. And 80% of end-stage renal disease is caused by diabetes, hypertension, or a combination of both. It is therefore important that we screen for albuminuria in these individuals so we can intervene and hopefully stop the progression to ESRD. Indeed, the importance of diabetes in end-stage renal disease has led to a collaboration between the International Society of Nephrology and the International Diabetes Federation to try and look at this issue and try and help prevent our people with diabetes going on to this horrific condition. The IDF Diabetes Atlas in 2021 tells us there are 537 million adults living worldwide with diabetes. That's 1 in 10 of the population. Interestingly, though, the Diabetes Atlas of 2003 said that by 2025, there will be 333 million people with diabetes. As you can see, we have already exceeded that number in this year. The Atlas goes on to say that the total number of people with diabetes is predicted to rise to 643 million by 2030. And by 2045, there will be 784 million people living with diabetes worldwide. That's 1 in 8 adults, a phenomenal number of people with diabetes. And 4 in 5 of people with diabetes will live in low and middle income countries. So this prevalence, you can see, worldwide is increasing dramatically, with the major increases of up to 134% in the prevalence of diabetes in Africa. If you look back at the Diabetes Atlas of 2011, it states that 50% of diabetes is undiagnosed. And I'll come back to that in a little while. So how can we monitor glycemic control? Well, the basis always was we measured blood glucose. But as you can see here, glucose is lost from the sample almost as soon as it is taken. And this loss in glucose in the sample is similar over the first 1 to 2 hours if the sample is preserved with fluid oxalate or if the sample is unpreserved. After about 2 hours, the sample that is preserved stabilizes and doesn't lose any more glucose. So this effect in sampling is in addition to the effect of glucose concentration changes we see in individuals, especially in individuals with diabetes, throughout the day, especially pre and post food. So glucose is not a good marker for glycemia in individuals, whether they have diabetes or whether they do not. So luckily, it was a chance finding by Raber back in 1968, when he was electrophoresing the blood from people with diabetes. And he described an abnormal, fast-moving hemoglobin fraction. We now know that this is not an abnormal hemoglobin, but is glycated hemoglobin, or hemoglobin A1c, as we measure it these days. But what is hemoglobin A1c? Well, hemoglobin A1c is not like many things we measure in clinical laboratories. It's not, for example, like glucose or thyroxine. These are single molecular structures of known composition, and the concentration in the body is tightly regulated, and therefore the concentration is controlled. Hemoglobin A1c is a product of non-enzymatic glycation. This reaction follows the law of mass action, and the glycated hemoglobin formed is not a single molecular structure. So let's look in a little bit more detail of how hemoglobin A1c is formed. glucose will react to any protein in the body as long as the glucose is in the open chain format. Glucose will bind to any protein, usually at the lysine residues of that protein. Today we're going to talk about glycated hemoglobin, and hemoglobin is unique amongst proteins, whereas this open chain glucose binds to the N-terminal valine by preference in that protein. Glucose will bind to other parts of the hemoglobin molecule, but preferentially binds to the N-terminal valine. This then undergoes, so binding is taken by a two-stage reaction, so going backwards and forwards, forming a shift base. As you can see, there's a fully reversible reaction. If the glucose remains in the open chain format, this undergoes an Honorary rearrangement, where the double bond changes position. This stabilizes the ketoamine that is formed. And this ketoamine is then there for the life of that protein, or in terms of hemoglobin, for the life of the red cell. This first readily reversible reaction takes place over a number of hours. So the shift base is a transition from one to the other. This Honorary rearrangement takes place over several days. So the ketoamine formed is there for the life of that protein. Nothing drives this reaction. It follows the laws of mass action. So the outcome, the ketoamine, relies solely on the reactants within the reaction. So a name. The scientific name for glycation at the N-terminal valine of hemoglobin is hemoglobin beta chain blood N1-deoxyfructose 1-yle hemoglobin beta chain. A mouthful, you have to agree, but we can call it hemoglobin A1c. So what time scale does hemoglobin A1c reflect glycemia? We are told that hemoglobin A1c reflects 4 months prior to sampling. And that is true to a large extent. But if you look a bit more carefully at what we're seeing, the month just before blood sampling provides about 50% of the influence of that result. So glycemia 1 month up to sampling gives at least half of the effect of the result obtained. Only about 30% of the influence of that result comes to the month prior to the month of collection. And 4 months before that, only about 0.5% is actually associated with the result you are getting. So yes, hemoglobin A1c does reflect 4 months, but in reality, the greatest influence on the result is in the month just up to sample collection. So from the description of hemoglobin A1c, the measurement was introduced in the clinical laboratories for the assessment of time average glucose concentration. And this method is rapidly adopted worldwide by laboratories, and it significantly changed our ability to accurately assess the glycemic status of people with diabetes. But what assumptions do we have to make if hemoglobin A1c is to monitor glycemia? Well, think back to my reaction I showed a few slides ago. We have to assume that hemoglobin is present at a constant concentration. We have to assume the lifespan of the red cell is a constant. And we have to assume that the microenvironment within the red blood cell containing the hemoglobin is a constant. And only then does glucose become the only variable, and therefore hemoglobin A1c reflects the glucose concentration within the body. But are these true? Well, hemoglobin at a constant concentration is probably true within individuals. What about anemia? The lifespan of a red blood cell is a constant. We're all told in universities and medical school that red cells survive 120 days. And that is true to a large extent, but there's a variation around this date, around this time, in different individuals. The microenvironment is constant, again, probably true within individuals, but this may not be true between individuals. And therefore, we should consider individual treatment goals. And that is something I will touch on slightly later. So how can we measure hemoglobin A1c? Well, there's a number of method principles. When glucose binds to the N-terminal valine, and only to the N-terminal valine, this creates a small charge difference in the molecule. Glucose being there obviously creates a structural difference, and there's a chemical difference. So let's look at these. Cation exchange chromatography was the first method described to measure hemoglobin A1c. And cation exchange HPLC is probably the most widely recognized method by which we measure HbA1c globally. Methods based on HPLC have improved over the years. But now there are many, many other methods based on different techniques that we can utilize to measure hemoglobin A1c. Capillary electrophoresis also relies on charge separation. But here we can see the hemoglobin A1c is totally separated from hemoglobin A0, which is not the case for HPLC. Unfortunately, to achieve this level of separation, capillary electrophoresis is relatively slow. Therefore, we have to run several capillaries in parallel to achieve a throughput that is acceptable. Structural difference. Affinity chromatography makes use of boronic acid. This boronic acid will bind in a weak reaction to cis diols on the glucose moiety of glycated hemoglobin. If there's a glucose attached to the hemoglobin, it'll bind to the boronic acid, and the non-glycated hemoglobin will wash off the column. And this can be measured by colorimetry. We can then use a counterligand to wash off the glycated hemoglobin and again measure it by colorimetry. Note, this technique measures glycation not only at the N-terminal valine, but also at other sites within the hemoglobin molecule. Immunoassay. This is where an antibody is raised between 2 to 4 amino acids at the end of the glycated hemoglobin molecule. Can you imagine how difficult it must have been to raise an antibody against such a small difference of hemoglobin A1c and hemoglobin A0? Again, total hemoglobin is measured by colorimetry, and the hemoglobin A1c by immunoassay techniques, or whatever method being used by that instrumentation. And finally, chemical differences. Here we can see that enzymatic measurement of hemoglobin A1c. First, hemoglobin is measured by colorimetry. A protease is then used to actually split the hemoglobin molecule into a dipeptide and the glucose attached. And then the fructosyl peptide decarboxylase is used to actually produce a colored compound in combination with hydrogen peroxide. And by standardization, this method can be adopted to actually produce hemoglobin A1c. So does improving glucose control improve the outcome for people with diabetes? Well, this was actually shown to us for the first time in type 1 diabetics by the Diabetes Control and Complications trial in the US, first reported in 1993. A couple of years later, for type 2 diabetics, by the UK Prospective Diabetes Study, UKPDS, reported in 1998. The outcome of both trials were very similar in what they showed, but let's look first at the DCCT. For the first time, we saw that as glucose values increased within patients with diabetes, as shown by hemoglobin A1c, there was an increase in retinopathy, nephropathy, neuropathy, and microalbuminuria. As we see that as hemoglobin A1c values increase, so does the rate at which these complications increase. But we can look at this in the other way. If we lower hemoglobin A1c, then we lower the rates of retinopathy, nephropathy, neuropathy, etc. So lowering hemoglobin A1c, hence lowering blood glucose, was shown to be a beneficial effect in patients with type 1 diabetes. In type 2 diabetes in the UK PDS, it was shown that lowering hemoglobin A1c by just 1% had beneficial effects of lowering the death of diabetes from diabetes by 21%, lowering microvascular complications by 37%, and lowering the rate of myocardial infarctions by 14%. A small difference in hemoglobin A1c results resulted in a major improvement in the patient health of people with diabetes. And this is the first time we could prove for definite that improving glycemic control improves the outcome of people with diabetes. So in the laboratory, we were tasked with getting the right result. And what do I mean by this? Well, if you look back to those days in 1993 of hemoglobin A1c methods used in the clinical laboratory, we can see that different method groups produce a huge range in values for hemoglobin A1c. Because if you went into one laboratory, you might get a result of 3.6% by a method being used there. Or go to the laboratory, maybe only 2 or 3 miles away, you get a result of 6.5% using a different method. Well, you can see how smaller results, 1% difference, create a big difference in outcome. This is an unusable system. There was no standardization. This was uniquely addressed in America by the NGSP network. This used a primary reference laboratory and secondary reference laboratories to assign values to standards used in clinical laboratories to try and address this variability. This core laboratory used as its reference method a HpA1c described by Goldstein back in the 1986. Back in the 1980s, this was a highly optimized method for measuring hemoglobin A1c. Unfortunately, with modern methods, we now know this was not specific for hemoglobin A1c and was interfered with by other factors, which I'll come back to. But this created harmonization of results. And we can see with harmonization, the variability in the results obtained by different methods was limited. And we are now getting results far closer to what you would expect to get from standardization. But the International Federation of Clinical Chemistry recognized the importance of hemoglobin A1c and recognized the need for standardization of this fraction on a global picture. So in 1994, he created a working group for the standardization of hemoglobin A1c. And researchers from around the world, from America, from Europe, from Japan, from Australia, were brought together with the task of standardizing this assay on a global position. Now, this was difficult. It was the first time we was trying to do this, but it was so important that we worked very hard in trying to achieve this. The reference method so produced can be broken down into 3 areas: sample preparation, then enzymic cleavage using a glue-C to split the hemoglobin molecule into peptides, either with a glucose, the hemoglobin A1c peptide, or without the glucose, the hemoglobin A naught peptide. And these peptides could then be measured using HPLC mass spec and HPLC capillary electrophoresis. Both methods give identical results, and both methods are highly specific for hemoglobin A1c. These methods need to be calibrated, and this calibration was using pure hemoglobin A1c and pure hemoglobin A naught, which were derived using a number of fractionation techniques to arrive at pure fractions, which could be used to calibrate this reference measurement procedure. Now, this reference measurement procedure is not for use in our routine clinical laboratory. Indeed, it takes several days for the hemoglobin, for this reference procedure to be performed. But this reference procedure is now used in 18 laboratories around the world. And these 18 laboratories altogether analyze methods, analyze standards using these reference measurement procedures to produce values by which manufacturers can use within their own method group to devise standards. So we now have a global position where we now have global standardization. No matter where you are in the world, you should now produce the same results. Now you can see this in the latest CAP survey in America, hemoglobin A1c. You can see that the spread around the target values is now far, far less than pre-standardization. We're now seeing typically a range of results of about 5 millimoles per mole, or 0.5% spread of results. So in other words, standardization has brought results into the right area. We are now producing the right results for hemoglobin A1c. Following standardization, there was a meeting in Milan in 2007 where the IFCC hosted representation from the American Diabetes Association, from the European Association for the Study of Diabetes, and the International Diabetes Federation to discuss how we should report results from this method. A number of recommendations were made in a consensus statement. The two important ones are that the IFCC reference system for hemoglobin A1c represents the only valid anchor to implement standardization of this measurement. In other words, methods should be standardized using the IFCC reference measurement procedure. And that hemoglobin A1c results are to be reported worldwide in IFCC units, which actually are SI units of millimoles per mole, and derived NGSP units in percent terms. The SI unit, millimoles per mole, is actually millimoles of hemoglobin A1c per mole of hemoglobin A naught plus hemoglobin A1c. Some people have adopted this as reporting format, but many other people have actually stuck to reporting hemoglobin A1c in percent terms. I'm often asked why the IFCC values are lower than the NGSP values. You can see here on this graph that the IFCC values are in the blue and the NGSP values at the top, and the Swedish values are the closer values to the IFCC, the Japanese system in between. But why are they higher? Well, if you remember, I said that the anchor for the NGSP was the HPLC method described in the mid-80s, and that was non-specific. So if you look more closely, we find that the non-specific interference in the NGSP method resulted in a 1.5 to 2% hemoglobin A1c difference in what we were seeing. As I said earlier, in the IDF Diabetes Act of 2011, they were described as 50% of diabetics worldwide were undiagnosed. So can standardization help this problem? Well, yes, it can, because in 2011, the WHO recommended hemoglobin A1c to be used as a diagnostic test for diabetes. This is providing that strict quality assurance tests are used, and the method being used is aligned to the international reference method. In other words, the method being used is standardized with the IFCC procedure. And if this is the case, they said that 6.5% or 48 millimoles per mole is a cut point for diagnosing diabetes. That is type 2 diabetes, not type 1. So let's look at how type 2 diabetes forms. Type 2 diabetes is a timed development and differs in different people. And this moves from normal glycemia to dysglycemia into frank diabetes. As we can see, as this timeline develops, there's an increasing amount of cardiovascular disease and microvascular complications. And this is develops with time. And at the point at which we are now diagnosing diabetes, we can see that cardiovascular disease and microvascular complications have already established themselves. What we need to do is to actually diagnose this far earlier. Will hemoglobin A1c do this for us? Well, not in the individual patient. What it allows us to do is to look at a greater number of individuals. So we can screen. So as a population, we can actually intervene far earlier and therefore hopefully cut back on the complications related to diabetes. And we've seen this earlier, that there's a huge predicted increase in diabetes over the next 20 odd years, 130 odd % increase in Africa. What is driving this increase in the amount of diabetes? But let's look at one aspect of this. This is David, created back in 1501 to 1504 by Michelangelo. It's a wonderful statue, as you can see, in Florence. And I advise you, if you're ever there, to go and see this statue. It is magnificent. But if Michelangelo was sculpting David today, it would probably look slightly more like this. Unfortunately, obesity is a global problem and is driving the diabetes pandemic. What is happening? Why is obesity a problem? Well, it is the availability of cheap, energy-dense foods that are available to us globally. It costs so much less to buy poor food than to buy expensive, energy-efficient food. This is a cafe only about 20 miles from where I live. And on your plate, you can have all this for about £15 or 19 American dollars. And the cafe owner will give it to you free if you eat it within an hour. These energy-dense foods are driving a global problem, and we have to address that. So back to the laboratory. What is the role of the laboratory professional in the care of people with diabetes? Well, it is our responsibility to ensure that we have a well-calibrated system which is monitored by external quality assessment or proficiency testing. That will ensure that the accuracy of what we're doing is good. We need to maintain a quality system with good procedures for internal quality control. In other words, we need to ensure that our system is precise. Why is it so vital that good analytical quality is achieved? Well, let's look at this graph here. I mentioned a few minutes ago that diabetes can be usually diagnosed. So diabetes can be diagnosed with hemoglobin A1c, and the cut point is 6.5%. We also know that a value of less than 5.8% hemoglobin A1c confers a low risk of diabetes. That is only 7 millimoles per mole, or 0.7%. That is challenging for us in the laboratory, but getting the wrong result has a devastating effect on the individual with diabetes. Let's look at this graph here. This is an unselected population in America, where they looked at hemoglobin A1c values in patients, in individuals over 20 years of age. And you can see here, there's several people, many millions of people within this uncontrolled group actually will have diabetes. But let's look at this. The hemoglobin A1c bias of 1 millimole per mole, or 0.1%, will result in almost 1 million people being underdiagnosed. So accuracy is so important, hemoglobin A1c. And so is precision. If we look here at an imprecision in method analysis, again, related to this diabetic cutoff of 6.4% and a low risk of less than 5.8%, we see that if a method we're using has got an imprecision of more than 2% CV, then we run the risk of actually identifying somebody being diabetic on one day and non-diabetic on another. Imprecision is also very important, which is why we in the IFCC devised a method of actually looking at quality using sigma metrics. And sigma metrics actually is based around imprecision, here shown on the x-axis, and bias on the y-axis. And anything left of the black line shows you the quality your method is passing the quality procedures required for interpretation. And we use sigma metrics to look at results from 2,166 laboratories across Europe in 17 countries using 24 different manufacturers' methods. You can see here that all countries, or the vast majority of countries in Europe, were actually producing results which had a quality specification which was acceptable. And this star shows the mean overall results. What does this tell us? This tells us that the bias is very, very low. So standardization has actually pulled results into the correct numbers. But the imprecision still needs a bit of work. Imprecision still needs to improve. And this graph shows the different method groups that are being used. Overall, methods perform analytically well. The methods falling outside the 2 sigma line here are older methods. And as those methods drop off, we will see that overall the imprecision improves. But this is a challenge, and this challenge is more for manufacturers than us in the laboratory. Imprecision needs to be improved in these methods. But we have actually cracked the standardization program. Our accuracy is now very good. So is hemoglobin A1c what we hoped it to be? Well, there are some questions around interferences, hemoglobinopathies, anemia, renal failure, HIV, ethnicity and aging, all reportedly affect hemoglobin A1c measurement. So will new markers of glycemia replace hemoglobin A1c? Well, the new markers include glycated albumin, fructosamine, 1,5-anhydroglutathione, and of course blood glucose. Probably the greatest threat to hemoglobin A1c is the glycated albumin. But is this really a threat to the measurement of hemoglobin A1c? Well, I would say that currently there's little evidence around the use of hemoglobin A1c, around the use of glycated albumin. Targets are not clearly defined. There's a perceived lack of specificity for hyperglycemia, especially with fructosamine. They're potentially affected by protein concentrations, and lower values are found in obese subjects, which we already know is a problem. and is too short a time scale of measurement. So will glycated replace hemoglobin A1c? I suspect not in the foreseeable future. What about continuous glucose monitoring? This is the means by which individuals assess their own current glycemic status. This is a measurement that gives different information to hemoglobin A1c and should be considered complementary and additive rather than a replacement. So I will finish with another disease, COVID-19. This affected everybody. Around the world, everybody suffered with COVID-19. But diabetes even more so. If we look at this paper from Emma Barron and co-workers, we could see that as age increased, so did the death rate from COVID-19. But if you have type 1 diabetes or type 2 diabetes, the rate of death as you got older, every age point was higher. And why was this? Well, if you look at the same group of investigators, they looked at hemoglobin A1c, and they showed that as hemoglobin A1c increased, so did the rate of death from COVID-19. This in type 1 diabetes and in type 2 diabetes, we saw the same thing. As hemoglobin A1c increased, so did the rate of death from COVID-19. So we can use hemoglobin A1c, as we understand it now, to actually look at these patients and put them into treatment regimes. We could target our treatment at these people who had high hemoglobin A1cs to help prevent them dying from COVID-19. So having a correct value for hemoglobin A1c is vitally important. But to finish, let's look at the evolution of hemoglobin A1c in clinical practice. We started off with the discovery of this new hemoglobin A1c fraction. The recognition of the value of this hemoglobin A1c in clinical medicine. The DCCT and UK PDS studies, which showed for the first time that improving glucose concentrations had a beneficial outcome to people with diabetes. The IFCC standardization of results globally, which allowed target setting, not only on an individual basis, but also globally around the world. The availability of standardization allowed for the WHO to recommend its use for diagnosis. As our methods got better and better, and we had standardization, we recognized individual variation in hemoglobin A1c results. Therefore, we can look towards possibly in the future individual treatment goals, which fits into the change in clinical medicine to personalized medicine. So hemoglobin A1c remains the most important, in my mind, in measurement we do in the clinical laboratory. Thank you.
Thank you so much, Dr. John, for that presentation. So I thought before we answered questions, we would just return to that theoretical patient who I opened up our conversation with earlier today. And just to think about how hemoglobin A1c really helped her track her care from gestational diabetes to prediabetes to type 2 diabetes. So our patient met with a diabetic educator and a nutritionist, and she embarked on an exercise regimen and modified her diet to reduce the number of simple carbohydrates and increase her protein with each meal. And with that, she was able to bring her hemoglobin A1c down to less than 6.5% prior to pregnancy. And then she successfully conceived. She, of course, required careful glycemic monitoring throughout her pregnancy and insulin for the treatment of hyperglycemia, but went on to have a successful pregnancy. She plans to work with her healthcare providers to maintain good glycemic control and forestall many of the potential diabetic complications that you spoke about in today's presentation as possible. So really, whether it's an older individual or a person who may be planning pregnancy, there are many, many circumstances where hemoglobin A1c can really help us in the clinical management of patients. With one blood result, really get insight to what their glycemic control has been for certainly the last month, if not the last few months before that. So with that, I thought I might open it to some questions from our audience. Dr. John, the first question I see is, do abnormal hemoglobins and anemia, you started to allude to this, affect all hemoglobin A1c methods?
That's an interesting question. And we have to think what interference actually is. That the main problem with hemoglobin variance and anemia is the effect it has on the lifespan of the red cell. And we think of interference, we think of two things. Something that interferes directly with with the measurement itself. For instance, like bilirubin affecting the Jaffe reaction. That has an effect on the measurement. What we're seeing with these interferences is the interference on the biological aspect. So the change in what we've seen in biology, the lifespan of the red cell changes. And therefore, the change there will result in possibly the wrong result for the hemoglobin A1c. And that will affect all methods, because it's not affecting the method itself, it's affecting what you're measuring. Now, what we have to bear in mind here is how much of an effect that actually is. And I would argue to some extent that the changes we are seeing in the values produced in these situations for hemoglobinopathies and for anemia is well within the quality systems that we actually have. In other words, it doesn't take the values outside what we would expect to achieve within the quality management of our assays. So yes, it is an effect on the biology and not directly on the method, and that goes for all aspects in terms of HIV, in renal disease, etc. What we do have is in aging, as you get older, hemoglobin A1c levels do appear to increase, not associated with increasing glucose, and that is something we don't actually know why it's happening. But in all the other aspects you said there, it is effect on the biology and not on the method being used to measure hemoglobin A1c.
Okay. Another question I see coming in, you said that hemoglobin A1c can be used to diagnose type 2 diabetes. Why can't it be used to diagnose type 1? Again,
a fascinating question. And that's because of the development of the disease. As we talked about earlier, the progression to type 2 diabetes is slow and a progressive worsening of blood glucose. And this takes place over maybe years. It takes much time to go from normal glycemia through dysglycemia to diabetes, resulting in slowly increasing blood glucose. Type 1 is very different. Type 1 is derived by a continuous breakdown of the islet cells in the pancreas, which can take place over some years. But the development of type 1 diabetes is sudden, because at a point in time, the destruction of the cells reaches a point where no longer insulin can be produced to a point to control the glucose. So the development of type 1 diabetes takes place over a few weeks or a few months. So there's a rapid change in glucose. If you think about the development of hemoglobin A1c over the lifespan of that hemoglobin of about a month or so, 4 months or so, you can imagine the rapid change you see in type 1 diabetes is so much it will not give you a raised hemoglobin A1c. So it remains by far the best means of diagnosing type 1 diabetes is the clinical presentation, which sometimes is presented in diabetic ketoacidosis. It is a clinical presentation and a glucose measurement, and that will give it the diagnosis.
But you could still use it to monitor glycemic control after that diagnosis.
Oh, yes. Hemoglobin A1c will monitor glycemic control in both type 1 and type 2 diabetes.
Great. I think we probably have time for one last question. I see a question in our queue that says, you mentioned that glycated albumin, was too short a time measure. And can you explain a little bit more what you mean by that?
Interestingly, it goes back to what you asked secondly in the last question, is can you use hemoglobin A1c to measure type 1 and type 2 diabetics? Yes, you can. And the reason you can is because it's got quite a long time frame where you can look at the changes in glycemia over. If you think about diabetics, there's a huge range in the glucose concentration seen within individuals. And that range of glucose results is far greater in individuals with type 1 diabetes and type 2. The spread of results you get within the body in type 2 diabetics is actually quite small compared to type 1. So if you look at a range of results, for instance, if you had a cold or some illness, results can go up quite dramatically in type 1 diabetics, not so much in type 2. So if you've got a short measure, like glycated albumin, and the half-life of albumin is about 20 days, you've got a measure over a small time period. Therefore, if in that time period you had something that affected your glucose concentration, as you would in type 1 diabetics, then you're going to get totally the wrong outcome to your assessment. So if you're thinking about what you want to achieve, and if what you want to achieve is look at glycemia over a long time period, which is what you want, then glycated albumin in type 1 diabetes might be too short a time frame. It might be okay in type 2, but in type 1s, I think you have to consider that the time frame you're looking at may not reflect full glycemic control.
Excellent. Thank you again, Dr. John, for your time today and your important research. We would like to also thank LabRoots and our sponsor, Abbott, for underwriting today's educational webcast. Before we go, I'd like to thank the audience for joining us today and their interesting questions. Questions that we did not have time for today, and those submitted during the on-demand period, will be addressed by the speaker via your contact information provided at the time of registration. This webcast can be viewed on demand. LabRoots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. Until next time, goodbye.
Okay, perfect. And then did you want to just really quickly start from the portion right after the Q&A so that way I can just make 2 versions of this just in case. And it's going to be, I think, if I'm remembering correctly, thank you for your presentation.
Yeah, I have the speaker notes. We can ditch the Q&A slide and I can speak over the Abbott slide again.
Perfect, just in case. I want to have both options available. So whenever you're ready, go ahead and start.
Thank you again, Dr. John, for your time today and your important research. We would also like to thank LabRoots and our sponsor, Abbott, for underwriting today's educational webcast. Before we go, I'd like to thank the audience for joining us today and for their interesting questions. Questions that we did not have time for today and those submitted during the on-demand period will be addressed by the speaker via the contact information you provided at the time of registration. This webcast can be viewed on demand. LabRoots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. Until next time, goodbye.